I'm Dr. John Kruse, and today I'm going to be talking about cognitive disengagement syndrome, which used to be called slow cognitive tempo, and its connection to ADHD. Cognitive disengagement syndrome is a collection of traits or behaviors include low energy, fatigue, social withdrawal, slow thoughts, daydreaming, zoned out, sort of spaciness, and it is strongly associated with but distinct from ADHD, and including inattentive ADHD. We know that slow cognitive tempo or cognitive disengagement syndrome increases the risk for isolation, for depression, for anxiety disorders, separate from whatever predisposition of those ADHD itself causes. And right now, as of August 2024, this is not an official diagnosis in either the DSM or in the World Health Organization classification of disorders, but there are people lobbying to have it placed in either of those systems. And the treatment for cognitive disengagement syndrome has not a lot of research, extensive research into it. The little there is suggests that some of the medications and some of the psychotherapeutic behavioral approaches that are useful in ADHD are helpful in cognitive disengagement syndrome, but we need much more data to be sure. And there's some evidence that Ritalin, and that's particularly Ritalin that's been studied, much less so than amphetamine so far, that Ritalin appears to be less effective for cognitive disengagement syndrome than it is for inattentive ADHD. So to jump into the topic more deeply, cognitive disengagement syndrome, again, is a collection of symptoms right now. It's not an official diagnosis. It's characterized simply by social and cognitive disengagement, low energy. Some have described it as being mired or full of task-unrelated thoughts. So you're not doing anything, you're sort of drifting or daydreaming. And in one of the research proposals for how to study it more, we don't have official criteria for diagnosing it because, again, it's not an official condition, but people who've been researching it, and it's been under research for 40 years now, we're tentatively breaking it down into 3 symptom clusters: a daydreaming cluster, a mental confusion cluster, and a hypo or low activity cluster. So in the daydreaming, that would include daydreaming, being lost in one's own thoughts. Those are considered separate symptoms. Being spaced out or zoned out, being lost in a fog, or staring blankly into space. Clearly, there's lots of overlap between, people who are doing one of those are fairly likely to be doing another. You might even have trouble differentiating, or in a symptom checklist, was that person zoned out or were they lost in a fog? For the mental confusion component, that was thought to consist of a cluster of symptoms, including loses a train of thought easily or readily, has difficulty putting thoughts into words, often forgets what someone is going to say, having thinking that is mixed up, being easily confused, and having thinking that is slow. So again, within that cluster, many of those symptoms clearly map onto each other very strongly, and it may even be difficult to discern, is their thinking mixed up, or are they easily confused? Almost always, if they check one, I would think you would be checking another. The other thing to be emphasizing that I neglected to begin with is many people are calling this an ADHD adjacent condition, and like ADHD, there is no single symptom that is completely definitive. All of these symptoms are things that almost everyone does at least some of the time. So it's the preponderance, pervasive patterns of engaging in these behaviors that are inappropriate or extreme for your age and your cultural background. Jumping back to the third components, we had daydreaming, we had mental confusion, and then we have hypoactivity or low activity. And that would include 4 symptoms of being easily fatigued or tired, having low levels measurably of activity, feeling drowsy or sleeping during the day, and having behavior that is measurably slowed down. Now, at least one study has conducted a factor analysis on these 16 different terms, and they found that rather than 3 clusters, that the core of cognitive disengagement syndrome seemed to cluster around 2 factors, and one was a cognitive disengagement, so that would include some of the mental confusion, some of the daydreaming, sort of blur into a cognitive disengagement factor, and a slowish sluggishness. So they would take the thinking is slow out of the mental confusion and lump it with the hypoactivity and slowed down behavior. So in that analysis, at least, it was slowness, sluggishness, and cognitive disengagement were 2 factors that seemed consistently to be pulled out. In terms of how is this seems to overlap or look to some people a lot like ADHD. Again, the thought is most of the cases of this up until fairly recently have been misdiagnosed or mistreated with ADHD. But again, we know from the results of researchers, and again, like ADHD, almost all the research, not all, but almost all, has been conducted in kids. But there are cases of pure cognitive disengagement syndrome without any ADHD significant symptomatology. So this cluster of symptoms can exist alone, but a third of those individuals who have inattentive ADHD, and some studies are as high as 60%. So if you have inattentive ADHD, probably at least a third of those individuals also have cognitive disengagement syndrome. Of those who have cognitive disengagement syndrome, and studies vary, but about half of them do have some ADHD significant symptomatology. When this originally was proposed or being considered, it was thought, again, slowness, sluggishness was characteristic. That seems very different than hyperactive, impulsive ADHD in particular. But according to the people who are researching it, there are even individuals who do have hyperactive, impulsive ADHD in combination with cognitive disengagement syndrome. How much of their behavior is slow and sluggish and how it's hyperactive, or whether most of their behaviors winds up at a normal speed because they're canceling each other out. I'm not sure how they're defining or looking at it. Many of the people who are pushing strongly to have this declared as separate diagnostic category or condition highlight that the 16 symptoms that I've just recounted are distinct and have no direct overlap with the symptoms that are the 18 symptoms that are used for diagnosing ADHD. I would argue that that statement may be true at some level, but it's true because these criteria for for cognitive disengagement syndrome were intentionally written so that they did not overlap. That doesn't mean these entities are really separate or distinct. So I'd say that sentence or that claim, which is almost always repeated, is highly misleading. To begin with, we know that the official criteria for ADHD, those 9 inattentive and 9 hyperactive and impulsive symptoms, don't do a very good job of mapping the full range of ADHD itself. So none of them directly or strongly address time management problems. None of them address the emotional dysregulation that's very common in ADHD. So to say that your new set of criteria don't overlap with a set of criteria for a different condition, or supposedly different condition, that we know is poorly defined or imperfectly defined, you're not on a very strong ground for using that itself as an argument for it being something distinct and separate. The other thing is that there are 2 of those classic inattentive ADHD symptoms that I would argue pretty clearly do directly overlap with a broad number of the cognitive disengagement symptoms. So those are ADHD inattentive symptom that's described as often has difficulty sustaining attention in tasks or play activities. For example, has difficult remaining focused during lectures, conversations, or lengthy reading. That's hard to argue that that doesn't actually directly describe some of those cognitive disengagement syndromes. And usually the third one on many of the lists, they don't have to be in any specific order, But another inattentive ADHD symptom is often does not seem to listen when spoken to directly. For example, and the for example is explicitly written into the DSM, their mind seems elsewhere, even in the absence of any obvious distraction. Some people who try to delve more deeply into how to differentiate cognitive disengagement syndrome from an inattentive ADHD focus on how we focus. So in ADHD, the problems with focus are thought to be distractibility, troubles with execution and planning, and more having executive function deficits that interrupt focus. Whereas the cognitive disengagement syndrome problem with focus is attributed more to internal distraction. People have trouble chasing down and maintaining their focus. And this feeds into a general neurobiological construct that there's at least two different major attentional systems. One is called the Dorsal Attentional System Network, often abbreviated as DAN. So DAN is considered a top-down system. So it is how your brain chooses what's important to focus on and then maintains a tracking of that. And that is largely involved not in the frontal cortex, but parietal lobes and further back. There is some evidence in, I think, just one or two studies of different activity in the dorsal attentional network in people with cognitive disengagement syndrome. And there is some evidence in another study that the DAN is larger. And you think, well, if this is a problematic area, why is it larger? The thought is there was less pruning, so there's more extensive synaptic connections left, leading to more confusion, leading to more wandering, leading to more crosstalk and less clarity in picking out what's important and sticking with it. So the other, and again, these are oversimplifications, but the other attentional system is called the Ventral attentional system, and that's considered a bottom-up. And what that means is it's not your thinking or your choices or your higher cognitive processes deciding what you want to focus on. That's how you respond to what's going on in the environment around you, the distractions, the noise, something pretty comes up. And the Ventral attentional network system, more of it is forward or tied into frontal processes and other areas deeper in the brain, and that's thought to be more involved with core aspects of ADHD, whereas the dorsal, the top-down attentional network, is thought to be involved in cognitive disengagement syndrome. Also, so another area where it looks like there might be overlap between ADHD and CDS, so cognitive disengagement syndrome, is poor task completion. Happens in both of them, but in ADHD, it's usually due to, the claim is external distractions, forgetfulness, trouble sustaining mental effort, whereas the claim is that with CDS, it's just that it's taking longer to complete tasks because there's slower movements in general, and you're going on a more meandering path, and that the distractions are thought to be internal distractions. I'm a little dubious of some of that because I think people who I've worked with and talked with and who describe what's going on, and you can see it in certain politicians right now when they are talking. Yes, some of their distractiveness is they see someone speaking out in the crowd, they see something else going on and have to respond to that, but they are also responding to internal distractions. You see them jumping from topic to topic that nobody else sees a connection to except in their own brain. That's an internal distraction, and these are individuals who aren't displaying any of the other core symptoms, I would argue, of slow cognitive tempo or cognitive disengagement syndrome. So claiming that internal distractions are specific to cognitive disengagement syndrome and that external distractions are the hallmark of distractibility for ADHD, I have trouble swallowing that one completely. And a third area that people try to make a significant distinction in is that with CDS, cognitive disengagement syndrome, Shyness, social withdrawal, loneliness are particularly associated above and beyond the extent to which those are all connected with ADHD. And in particular, trying to break down the social disengagement, there are both elements of shyness and social disinterest or disinterest that can be measured in CDS, although the studies that have tried to look more closely have found that shyness seems to be a bigger factor, but both are present, and that shyness in CDS is present to a greater extent than it is in inattentive ADHD, and shyness is considered to be on the anxiety spectrum. It's the presence of our thoughts of interacting create some fear, worry, anxiety elements. The research is pretty consistent that CDS is associated with anxiety disorders, depression disorders, beyond any contribution coming from ADHD, which already predisposes people to that. There seem to be predispositions to suicide, maybe to some other physical health problems as well. One other factor, and there's only a small bit of evidence, but there's some evidence that at least throughout childhood, the trajectory for CDS may be to worsen throughout childhood as one gets older. Whereas with ADHD, the general thought is that, and this is an oversimplification and individuals have their own patterns, but with ADHD, it's roughly, you have it to a roughly constant degree of ADHD-ness, but the demands of the situation and the support you may be getting from your environment may vary significantly, and why we see people showing up for treatment when they get to high school, when they get to college, when they start a job, when they start retirement, aren't because of the underlying severity of the ADHD changing as much as the fact that either greater demands were put on the person or there was less support from their environment, or both together. And the causes of CDS, we don't know. Not a huge amount has been researched into this area, but the little bit we have suggests there are, again, a few studies suggest there's significant genetic contribution to this. There's certainly environmental factors. So fetal alcohol syndrome often seems to predispose people to, again, not just ADHD symptoms, but to CDS symptoms, and brain trauma can also be a precursor to the onset of CDS symptoms. And jumping onto the treatment area, the treatment of CDS, again, there's a few studies, not a lot, most of it in children, many of them open studies, not rigorously conducted, double-blind, placebo studies. So in terms of medications being used to treat it, there's a few studies that suggest that the presence of CDS in someone with ADHD renders methylphenidate less likely to be effective than if they just have pure ADHD. So Ritalin seems to work less well in the presence of cognitive disengagement syndrome. On the other hand, there are studies that show that Ritalin can have some measurable improvement on CDS symptoms itself. So that sounds contradictory a little bit, but we're talking about, in one situation, lower rates of response, not no rates of response. There are also a few studies looking at atomoxetine strattera with improvement in both, again, cognitive disengagement symptoms, which can be statistically separated out from just the improvement in ADHD symptoms, often because the risks are thought to be higher with stimulants like methylphenidate. That's used. There might be less willingness, even if the two were equally effective, to go that route. And there is conjecture and statements from experts in this area, which probably means they have tried it in some of their own patients without yet having published too many studies or case reports, that cognitive disengagement syndrome is likely to be responsive at least partly to modafinil and to bupropion, Wellbutrin. There's also claims, and again, not a lot of rigorous studies, that many of the cognitive behavioral approaches, many of the educational approaches helps with improving attention, directing focus and attention, sustaining it. Many of those tools may be helpful in this situation, but it's not clear it all. So at this stage, again, cognitive disengagement syndrome is not an official disorder. It does seem to be a collection of traits. And again, there is data that suggests that these traits really cohere together. They really are there is consistency and validity to the internal diagnosis. How common it is. Some also are objecting that we shouldn't be over-pathologizing what are just a different way of being in the world. But the counter to that is, although this is different, this is a different that is associated with poor educational outcomes, poor social outcomes, poor financial outcomes, much like ADHD, and probably higher rates of death like ADHD. The other sort of objections so far to considering this a disease is that although there's been a little bit of replication in Turkey, Iran, Japan, most of the studies have been done in Europe and particularly the US, and particularly done by Russell Barkley and colleagues, and also by a group at the University of Cincinnati. Russell Barkley clearly is intelligent and does extremely rigorously well done research, so that makes it, in my eyes, more trustworthy than someone else might be doing it, but we do need greater replication by a broader range of groups who are studying this and a broader range of age groups. And part of my own biases or thoughts on this, when I look back on 30 years of working with individuals with ADHD and inattentive ADHD, and again, I think many individuals who come in telling me they have inattentive ADHD, and I've talked about this in my video on inattentive ADHD, many of them have combined type ADHD. Many of them are apparently just less aware of again, symptoms of hyperactivity do tend to diminish or change as people get older, but people are talking loud or talking aggressively, leaning in, behaving in ways that are hyperactive and impulsive and not aware. I would classify in the hyperactive spectrum and combined type. So anyway, I haven't seen anyone that I think would fit a pure cognitive disengagement syndrome picture. I've seen certainly some people with some substantial symptoms, some subset of those symptoms that overlap with their ADHD. I've particularly seen in the 10, 20 years ago when we were diagnosing, or people were self-diagnosing chronic fatigue immunodisorder syndrome, CFIDS more often, I'd say there's a large overlap there, and with post-COVID brain fog disorders. So I'm certainly seeing some of the symptomatology. It sort of reminds me of the situation. I did research in the early 80s on seasonal affective disorder. I believe it really exists in a pure form. And I rigorously asked all patients who came in with depression about the seasonality. And maybe some of it was my career was in San Francisco, not where medical school and PhD land. We're in Rochester, where the seasonality is much more apparent. But I saw very many fewer cases of pure seasonal affective disorder than the research would make me think. So one reason I think, particularly in adults, that you are much less likely to see pure cases or primary cases of cognitive disengagement syndrome is, again, what's classic is not just cognitive disengagement, but social disengagement. And so if you're a kid who's not interacting with their classmates, who's off in a dream, the teachers and your parents are likely to notice, likely to potentially consider it problematic, and likely to push you into treatment. If you're an adult who's off in their own world, daydreaming by themselves, where your motivation's low, your energy is low, you may be shy and have some social discomfort, that's not a group that's likely to be motivated to come in for treatment, even if, again, there is some considerable overlap or predisposition to depression and anxiety symptoms. I will be having a question and answer session in a few days on this topic. Stay healthy, stay happy, and I'll be happy to try to answer questions about this in a few days.